and a hearty welcome to everyone. Dear attendees, thank you for taking time out of your busy schedule and being a part of today's webinar on COVID-19 management and vaccination. It is our great honor to be able to organize this webinar for our frontline health workers who have been sacrificing their personal lives and jeopardizing their own and their family's safety in service to their society and the country as a whole. Today, at this very moment, I'd like to use this platform to express my sincerest gratitude to all our frontline health workers. Thank you for everything. You all are the true superheroes. Taking into account the havoc created by the COVID pandemic and the challenges faced by our frontline health workers on a day-to-day basis, we came to realize that it's about time we have an academic discussion as well as reflect and analyze several aspects related to COVID-19 management and vaccination. To address this very curiosity and quench our attendees' ever-growing thirst for knowledge, we present to you this webinar on COVID-19 management and vaccination. Namaste, everyone. I am Drishti Giri from National Youth Movement Nepal, and I will be one of your hosts for today's event. I would like to welcome my co-host for the event. Pooja, the screen is yours.
Thank you, Drishti. Namaste, everyone. I am Pooja Rokaya from NYM Nepal. This webinar is organized by National Youth Movement Nepal. National Youth Movement Nepal initiated with the objective of developing youth leadership by empowering and awakening Nepali youth. It is the national network of Nepalese youth of diverse background united to develop leadership and capacity building among Nepalese youth, contributing to the development and prosperity of Nepal. During this ongoing pandemic, we have built a prototype of oxygen concentrator, which is in testing phase currently. Similarly, in order to meet the ever-increasing demand of blood during this pandemic, we are also organizing a mobile blood donation in Kathmandu Valley. I would also like to take this opportunity to acknowledge our collaborating partners for the event, Nepal Health Corps, America Nepal Medical Foundation, and Paila Foundation. Thank you so much for your support. Now, without further ado, I would like to introduce our speakers for the webinar. For the discussion of COVID-19 vaccination, we have our speaker, Dr. Ramit Thapa, Infectious Disease and Antimicrobial Stewardship Director from UPMC, Western Maryland, and board member of America Nepal Medical Foundation. And for the discussion of COVID-19 management, we have Dr. Raju Century, Pulmonary and Critical Care Attending Physician in Winchester Medical Center, Virginia, and board member of America Nepal Medical Foundation.
Before handing over the platform to our eminent speakers, I'd like to inform you that we'd be highly pleased to receive your questions and queries to our speakers on matters related to COVID-19 management and vaccination. We will have time for your questions at the end. With this, without any further delay, may I please have the honor of requesting our first speaker, Dr. Ramit Thapa, to share his expertise with all our attendees here joining with us today. Sir, the screen is yours.
All right, thank you, Drishti and Pooja, and the entire Nepal Youth Movement team for giving me this opportunity to share some of my views on COVID-19 vaccines. And Dr. Raju Century will be talking about the management. Let me just make sure I'm able to share my screen. All right, you can give me a thumbs up if everything is working on your end. But the topic for today that I'll be talking about is giving an overview of the COVID-19 vaccine. The objectives for today's discussion is getting to understand why vaccination is necessary, how vaccines work, and what are the different types of vaccines that are available right now for COVID-19. And also to understand about vaccine efficacy and to know what the numbers actually mean. We'll also talk about giving vaccines to different special populations, including pregnancy, breastfeeding, as well as immunocompromised adults, and also to bust some myths about vaccination that are going around in the community. So first of all, what is a vaccine? It is very important to understand the definition of a vaccine. And by definition, it is a product that stimulates a person's immune system to produce immunity to a specific disease. So by definition, vaccine does not prevent you from getting the infection. The preventive measures that have been recommended, such as social distancing, hand hygiene, wearing a mask, those are still very important public health measures to get the infection in the first place. But in the event that you are exposed to the infection, then the role of vaccination is to reduce the number of infections. So it reduces not only asymptomatic infections, but also how severe infection you're going to get. So in turn, it reduces the number of hospitalizations and deaths. And as you all are aware, Nepal is already battling with difficulties and scarcities related to healthcare and oxygen supplies. And the role of vaccination is crucial in controlling the pandemic. So what does the vaccine do? The vaccine trains your immune system to recognize the virus in the event that you encounter the virus after vaccination. And the human body has its own immune system, which is very complex, but includes the T cells as well as B cells, and they have different roles. And some of you who are already completed medical school are aware that B cells are, their role is for making antibodies, whereas T cells, they help in making further B cells and memory cells. So I'm just going to talk a little bit about the virology. And of course, by now, everybody has seen the picture of the coronavirus. And in its core, it has the nucleocapsid protein as well as the RNA, which encodes the genetic material for different proteins. And these are the structural proteins, including the membrane proteins, and also very popular, the spike protein, which is on the surface. And they have their initials as S protein and M protein. So once the virus enters the human endothelium, there are certain receptors called ACE2 receptors, which stands for angiotensin converting enzyme. And these are in the lung where the virus is able to enter the cell. And I don't want to talk into too much details about the pathophysiology, but just want the attendees to have an understanding of, what normally happens after viral entry, where the genetic material is released into the host cell. And then once the RNA is released, it uses the host mechanism that is already in place to produce more viral particles. So the role of the virus is very simple. It only wants to replicate and form more viral particles. But the effects of that multiplication is that it drives the human immune system with the T lymphocytes, neutrophils, monocytes, and macrophages, which produces all these cytokines, which are chemical messengers, and in turn they drive an inflammatory response, and that can cause severe pulmonary symptoms. So if you look up the WHO website, it has a live number of vaccines that are in clinical development, as well as other things that are being developed for as far as vaccine candidates. And just to give you a brief comparison of about the different types of vaccines that are available, there are some that have already been used for many years and decades, and some vaccines that are relatively new that are being introduced for human use. So the first type in the table is the DNA and RNA virus. So Pfizer and Moderna vaccines that use the messenger RNA or mRNA. And these vaccines are being used for the first time in such large scale, but they are found to be very effective. Now, the live attenuated vaccines are vaccines that use a weakened version of the actual vaccine virus, and similar vaccines would be MMR vaccine or the chickenpox vaccine that are already in use. Inactivated vaccines are vaccines that are being used after the virus is either killed with heat or chemicals. And an example would be a polio vaccine. And as far as COVID-19 candidate, the Sinopharm vaccine is an inactivated vaccine. Similarly, a subunit vaccine is when the vaccine uses only a portion of the virus to stimulate your immune system. Pertussis, hepatitis B, and HPV vaccines are examples that are of similar vaccines that are in use. And then finally, there's also a viral vector, which can be used as the vaccine approach, where we take a harmless virus and use it to deliver viral genes to build immunity. And the Oxford AstraZeneca or Johnson & Johnson are examples of such vaccines. So just to go into a little more depth about the mechanism of action of vaccines, and to briefly give you an overview about the normal human DNA transcription and translation, where human DNA is transcribed into human mRNA, and then in turn with the ribosomes is translated into human proteins. So the adenovirus vaccines use DNA with the genetic encoding for the mRNA, specifically to the spike protein. And once it enters the human cell, spike proteins can be made. And going into further detail, so the chimpanzee adenovirus is the viral vector that is being used in the Oxford AstraZeneca vaccine. I might have to request some of the users to mute their microphones, please. Thank you. And then, so the viral vector, even though it's a virus and in an adenovirus, it is unable to cause human disease. And we use it as a vector, meaning as a media to transport the genetic material. So on the left-hand side, you'll see the coronavirus, where although it's an RNA virus, there is gene sequencing, and the DNA can be incorporated into the adenovirus vector, and now it is packaged into a vaccine. And once it enters the human body, the host immune system is triggered, and is able to offer protection. Now, a different approach where Moderna and Pfizer have used messenger RNA vaccine approach. And once the vaccine is injected, there are two ways where immunity is obtained. One is the muscle cell itself, where the RNA is released into the muscle cell, and the host mechanism that is already in place with ribosomes, they are able to make the spike protein. And again, don't want to go into too much details about immunology, but there is major histocompatibility complex 1, which presents the antigens to the CD8 T helper cells, and also in the draining lymph nodes, where again, the spike protein is again presented in conjunction with CD4 helper T cells. So this is how the immune system is primed, and so that when you are actually exposed to the virus in future, you already have some kind of immunity. Now, the inactivated coronavirus, basically, like I said, is already killed and cannot cause infection, but the body recognizes it as a foreign body, and there is cells called antigen presenting cells, which again, in conjunction with helper T cells, are able to produce an immune response. So one thing to remember, though, is there's a difference between natural infection and vaccination. When you have a natural infection, there is different immune mechanisms that are targeting not just the spike protein, but also the membrane protein and the nucleocapsid protein. So, and there is a host of protective responses that occur that could be different from a vaccine. So each vaccine and its mechanism of action could elicit a different kind of post-immune response. So the development process, you might be aware there's phase 1, phase 2, and different phases of vaccine development. And initially, they want to make sure that out of those hundreds of candidates, is the vaccine safe? Does it work? So there are different phases which the manufacturing companies and pharmaceuticals, they have to go through before a product is actually available for public. Moving on to vaccine efficacy and effectiveness. So this is something that people need to understand and actually have a good understanding of what these numbers mean that are being thrown out there about vaccine efficacy. So vaccine efficacy refers to how well a vaccine performs in a carefully controlled clinical trial, whereas vaccine effectiveness describes its performance in real-world observational studies. So these are observational numbers, that are calculated from a clinical trial. And the bottom line is that all the authorized COVID-19 vaccines are both efficacious as well as effective against COVID-19. So there is actually a formula based on the numbers that are generated in the clinical trials that are used to calculate vaccine effectiveness. But to understand the principle, it is actually the percentage reduction in risk of disease among vaccinated persons relative to unvaccinated persons. So you guys can review the formula, but just as an example of the Pfizer vaccine, out of about 21,669 people who were vaccinated, only 9 people had infection after more than 7 days. Whereas in the placebo group who were not vaccinated, about 172 people got the infection. So the percent reduction compared to the unvaccinated group was 95%. The common misconception is that a vaccine is 95% protective. So laymen are interpreting like, Pfizer versus Moderna, 94% versus 95%, and trying to get which one is better, and thinking that one will offer 95% protection. That's not really the case. It just means the numbers in the trial, there was certain percent reduction. It might be a little bit confusing, and I'm happy to take questions at the end of the presentation. So there's more data coming. Again, we have been in this pandemic for more than a year now, and once the vaccines have been rolled out, there's more data that is coming out right now, and there will be more data coming out next year. So a lot of the things that will be known next year right now is up in the air. So if you look at the effectiveness of COVID-19 vaccination, there's trials ongoing in different parts of the world where they have looked at in vaccinated people, healthcare workers, even the people have been getting asymptomatic infection. So if you look at the vaccine effectiveness in this population, it's slightly lower than the initial trials. So anywhere from 60% to 80%. So what I'm trying to say is that vaccine efficacy and effectiveness, there are a lot of factors. And these trials, they have been done mostly in a controlled environment with social distancing. There is lockdown in place in most parts of the world. And people have been adhering to outdoor masking, indoor masking, hand hygiene, sanitation. So the numbers actually, at the end of the day, they're just numbers in a trial. It's not real world numbers. So to put things into perspective, if you look at the effectiveness of seasonal flu vaccines, and this is data from the CDC, most years it's anywhere from 40 to 60%. So millions of people who receive the influenza vaccine, we don't ask questions how effective the vaccine was or which brand of vaccine we got. We're getting them this billion-dollar industry, every year pharmaceutical companies are making. And the vaccine effectiveness is actually about 40%. So you have to put things into perspective. And now with a COVID vaccine, everything is new, where people have been wanting to get, which one is better? I want Pfizer, I want Moderna, oh, the Sinopharm is not good. So I don't think we should really have that conversation where we're comparing different vaccines based on the efficacy that's been thrown out there. So next few slides will be just some data that has been published about the efficacy and safety. First one is the mRNA-1273, which is just another name for the Moderna vaccine. And again, both Moderna and Pfizer had about 95% efficacy. Most often side effects would be local reaction. And this is very natural. That's what the vaccine is supposed to do. If you had side effects, that means the vaccine is working. So local pain, swelling, some people can have chills, myalgias, fevers. These are all expected. And compared to previous immunization, and possibly because these vaccines are newer, very effective, but these adverse effects do occur in a lot of the patients. The same thing with the Pfizer, about 95% efficacy was observed, and similar side effects. Now, the talk of the town was Oxford AstraZeneca vaccine in Nepal, because Covishield vaccine that was offered to Nepal by the Indian government was actually manufactured by Oxford AstraZeneca. And in the trials, there was about 23,000 people enrolled. And again, these are 2-dose vaccines with second dose about 4 to 12 weeks apart. And even though the efficacy reported was about 70%, again, if you don't mind, please mute your microphones, whoever is joining in. Thank you. And despite a later arrival, what we have to realize is the AstraZeneca vaccine can be stored, transported, as well as handled in conditions between 36 and 46 degrees Fahrenheit. So for poorer countries, low-income countries, this is a better choice. Moving on to the Johnson & Johnson vaccine, again, the efficacy is about 66%. However, the advantage is that single dose is necessary. So even in the United States, there's millions of people who only got 1 dose out of the 2 doses that was recommended for the Pfizer or Moderna vaccine. So when you have a single dose vaccine, that does tend to increase the compliance rate. There was an issue that I wanted to mention, that there was a rare side effect with thrombosis, specifically thrombocytopenic syndrome that was seen in women. Moderators, can you please try to mute some of the participants? All right, thanks. What I want to mention is that these are very rare. So about 7 cases per million doses. And what CDC decided was that the benefits of the vaccine still outweighed the risk, but they did mention that if for women less than 50 years, if there is an option to get either the Pfizer or the Moderna vaccine, then that might be a better choice. And also, Sinopharm vaccine will be available to some of the citizens in Nepal, and about 79% efficacy was noted in the trials. The COVID-19 vaccine process is actually very lengthy, thorough. Each and every vial has been inspected. So from the vaccine development to distribution and delivery, each step is controlled and monitored. So I just wanted to bring this slide up to note that it's very safe. Moving on to safety in different populations, of course, pregnancy is always a concern because of the fetus, but having COVID-19 is always worse in pregnant people because they're at increased risk for severe illness. And there's no known risk associated with giving these vaccinations. The vaccine itself cannot cause infection, and CDC has recommended that COVID-19 vaccine can be given in pregnant women. However, it is important to note that in the initial clinical trials, there were very few people who were enrolled to look for safety. And this is something anecdotal, but those who were in the trials did end up getting pregnant. So there's no proven risk. Same thing with breastfeeding women, no risk associated with giving these vaccines while breastfeeding. There's also a lot of questions being asked about safety in immunocompromised adults. And the question actually is not how safe these vaccines are, but actually, is it efficacious? Because immunocompromised adults can be on different medications that are immunomodulators or immunosuppressants. So how effective the vaccine is going to be in this patient population is unknown. They were excluded from initial trials, but again, there is no increased risk or risk for serious adverse effects from the vaccine. Another question that frequently arises is if you had the shingles vaccine or flu shot or any other vaccine, can the vaccine be given? Do you have to wait? An initial recommendation was that you have to wait for about 14 days, but they lifted that recommendation. So now you can be, the COVID-19 vaccine can be administered simultaneously. So what about vaccination after infection? This is also a frequent question, especially since a lot of people have already had the infection. So you don't have to wait 90 days. Initial recommendation was, you have to wait 90 days. But then what studies have shown is that your natural immunity is probably good. It is very less likely that you're going to get infected in the first 3 months after an infection. So you don't have to get the vaccine during that time. But if the vaccine is available and you want to get it, once you have recovered from the initial infection and isolation has been discontinued, then you can get the vaccine. What about anticoagulation? There is no recommendation that people should be on anticoagulation or on aspirin before vaccination. There is no contraindication for people who are on anticoagulations that they cannot get the vaccine. So again, very safe. Also, there is inappropriate testing about proof of immunity. People want to check for antibody levels to see if they're immune, if they need the vaccine. At this time, there's no recommendation to assess for immunity of either following COVID-19 vaccination or to check whether somebody is a candidate for COVID-19 vaccines. Just a couple of minutes to talk about common myths. One is that COVID-19 vaccine can affect women's fertility. And this statement is false. There were social media posts stating that the spike protein on the virus was the same as another protein that is involved in the growth of placenta, and that is not true. So again, during the trials, there were 23 women volunteers who actually became pregnant. And the only one who suffered a pregnancy loss was actually in the placebo group. So again, this is not true. So if you hear somebody talk about infertility, that is incorrect. Another question is, if you get the COVID-19 vaccine, will you have a positive test? This is again not possible. Most likely, patients who have a positive test after vaccines actually had an exposure. So you need about 2 weeks for the vaccine to be effective after the second dose. So between the first dose or even before the first dose, if you have an exposure, your body's immune system is not primed yet. So you can still get the infection despite being vaccinated. And it's not because of the vaccine that you had a positive test, but it's because you had an exposure. Another worry that people have is whether researchers rush the development of the vaccine, so we cannot trust it. And in the United States, unfortunately, more than 50% of the population, they have doubts about the vaccine. They are refusing to get the vaccine. So there's been a lot of push about getting the population vaccinated. But like I mentioned, the process is rigorous and robust and very safe and effective. Does the mRNA vaccine change your DNA? No. Again, the mRNA actually gets broken down in the host cell, so it does not get incorporated into the DNA and have any long-term effects. So what we don't know is that we're still in a learning process where we don't know how long the vaccines protect people. Again, like I said before, more data is coming up. There are some articles with preliminary data in about 30, 40 volunteers who have been vaccinated where the antibody levels have been good for more than 6 months. But we'll have more data next year, and then we'll be able to say whether a booster dose is necessary. There is, again, some preliminary data from Moderna about the modified mRNA vaccines based on the newer strains, and those were offering better protection, so they might come up with that next year. But the initial goal is still giving vaccination to the countries who don't have access to vaccines. So the current scenario in Nepal is that although 1 million doses were supplied in February, the government refused to supply the second dose. So a lot of patient population have been stuck in limbo with just 1 dose. However, Nepal will receive doses from China and also from the United States. But details have not been put out to public yet. So unfortunately, the sad part is that there is discrepancy in vaccine distribution in developed countries versus underdeveloped countries. And again, this is just the number of doses. So like I said, in the United States, about less than 50% of the population have been vaccinated. But in Nepal, unfortunately, it's less than 7%. So, hopefully things will change. We will be able to get more help from the developed countries, China and US. But in summary, I would just want to mention that all vaccines, whatever is available is still safe and effective. So when it's your turn, please go ahead and get the vaccine. And not just the vaccine, but continue other preventive measures to wear a mask appropriately and correctly to stop the spread of infection, hand hygiene, disinfecting common surfaces. So these things are still important because, not just COVID, but all other infections, the numbers have decreased because of this measure. So while we're waiting for vaccination, preventive measures is still important. So with that, I'd like to, again, thank all the frontline healthcare workers as well as the organizers for letting me participate and share some of my thoughts. I will hand over to the moderators, Trishti and Pooja.
Thank you, sir. It was an extremely enlightening presentation, and I'm sure I speak for everyone attending this webinar today. Dear attendees, we are seeing a lot of questions coming in through the chat box, and I'd like to inform you that we will be taking your questions right after our next speaker's presentation. Having said that, we encourage you to keep your questions coming, and our speakers will try to address as many queries as possible. I'd also like to inform you that we will be sharing the link to post-test in the chat box right after the session by our next speaker. You're all requested to fill the form before the webinar ends, and we will be handing out certificates only to those participants who fill out the post-test form. I repeat, we will be handing out certificates to only those participants who fill out the post-test form. Once again, I'd like to request everyone to mute themselves throughout the webinar. And now, moving on with today's event without any delay, may I please have the honor of inviting Dr. Raju Century to share with us all his expertise on the management of COVID-19.
Thank you, Drishti, and good evening, everybody from Nepal. I'm Raju Biswakarma, currently in a Winchester Medical Center in the United States. I'm going to share my experience in management of COVID-19. Let me share my slide. Does it look good? Can you see it? All right, let's proceed. Thank you, Dr. Amit, for highlighting all the important steps, information in the vaccination. So now it's more than 1 year that we've been fighting with this COVID. Now Nepal is in a fire. So what we learned in the last 1 year, I'm going to share with you. And this management limited depend on how much of resource you have, especially in Nepal, our healthcare system, wide variation. Some hospital can provide the care as a developing countries, and some hospital have so much of limited resource, and it will be so challenging to take care of this sick patient. So today, what I'm going to try to cover is etiology, important pathophysiologic aspect in the management of the disease. What are the different diagnostic testing we needed, and severity of disease, and how we manage differently in different severity of disease, and what are the complications you can come across while you managing this COVID-19 disease. Dr. Ramit already kind of touched upon this one. So as you know, this is caused by the SARS coronavirus 2. As Dr. Amit already mentioned, this coronavirus entered to the host via this ACE2 receptor. And the ACE2 receptor is expressed primarily in the airway epithelium. And this is airway-borne disease that we know, right? When we get the virus, it rapidly multiplies in the airway epithelium. But the study found that the virus can be anywhere in the body. If you see the higher gradient of the blue, they are the mostly where the virus you can find, like upper airway, mouth, lungs. That's where the testing is all from the nasopharyngeal swab, right? The symptoms is depending on the organ system involvement. The mostly is a non-specific symptoms, as you all know about the fever, myalgia, cough, sore throat. Those are the common presentation. So these two slides, I think, are two pictures are very important in the understanding of the how do we manage this disease, right? So as Dr. Ramit had already kind of touched upon this before, this is the picture of the alveolar capillary, alveolar bed, where this is alveolar side, this is alveolar epithelium, and this is a capillary endothelium, and this is the interstitium, alveolar capillary junction, right? So when we inhale the coronavirus, it infect the airway epithelium because that's where the ACE2 receptor are highly expressed, and also can infect the airway in the capillary endothelium. So when there is just the infection initial replication phase, you may not be any symptomatic, and these are the patients that a lot of patients are asymptomatic and they still a transmitter, right? As a natural immunity, when you get the virus in the cells, the T cell, neutrophil, and the macrophage get recruited in the site of the infection, then that's the time it produces a lot of cytokine. Because of that cytokine response, the patient will become symptomatic. Those are fever, myalgia, headache, and all those non-specific symptoms. Fortunately, 80 to 90% of patients recover from this phase. So they will not get sick, and the patient, oh, I just had a mild fever and cough and I recover in the second week, and usually within a week, this thing get better. And this should be the balanced way. So if the cytokine response is there and it prevents the further replication of the virus, the patient will recover well without any consequence. The problem is when, the problem is when there is out of control inflammation. There is a lot of imbalance between the inflammation and the to kill the virus. That's the time the patient is in trouble. What happens is when there's excessive inflammation, you see this all endothelial lining. These are the endothelial cell, and there is a capillary leak. So because of the capillary, there's a lot of influx of the neutrophils and lymphocyte and macrophages, and that's caused a lot of inflammatory exudate in the alveoli. And that what will happen is there will be the thickening of the interstitium because of the capillary leak. There is a lot of exudative fluid in the airway epithelium, and the interstitium also got thickened. This time, what happened is there is a problem in the oxygen exchange. See here, still the alveolar bed is intact. That at this point, early phase, there is no hypoxia. The moment the patient started being hypoxic means there is a lot of inflammation going on. Now we are dealing with the aftermath of inflammation, not because of the viral replication. This is very important to understand when you're managing this patient, right? So at this point, the patient clinically will become hypoxia, and they will be coming with the dyspnea. They will be coming in the complaint of the, oh, I'm having trouble breathing. And in the meantime, if you check their pulse ox, they will be hypoxic. If any patient are hypoxic, you understand that you are dealing with the patient not with the viral replication, more so those having a lot of inflammation. At that point, the coagulation cascade also get activated, and we know that there's a lot of microthrombi in the capillary circulation, and if that is more aggravated, the patient can develop thrombotic complication like a DVT and pulmonary. This is very important pathophysiological aspect when you are treating this patient. So testing is primarily the testing. We know it is by the gene RNA detection by the PCR or antigen detection, which is a rapid test. Other testing are more so to rule out the differential diagnosis. These people presenting with these non-specific symptoms can have a COVID disease, but they could be just this positive to testing, but they can have other disease. So always make a due diligence to rule out all the other differential diagnoses. Usually in the CBC, you see the lymphopenia. You can check the CRP, D-dimer, ferritin, but depending on where the resource is, you may or you may not be able to check these markers. And all the other tests should be done only if that's going to make any change in your management, right? We have a lot of testing, but we should not be doing testing just for the sake of testing. And if that's not going to change what you're going to do, maybe that is not helpful, especially in our research setting. So this disease severity, most of the patients are mildly symptomatic, about 80%. And those who are hypoxic, they are already in a severe stage, and usually the chest X-ray, if you do the simple chest X-ray, more than 50% of the lung fields are involved. And if there's organ dysfunction, they're already in the critical care setting. Which patient likely to go to the severe disease, and which what are the poor prognostic factor? Those who have many comorbidities are known to have the bad disease, such as active cancer, immunocompromised patients, COPD, diabetes, chronic lung disease, uncontrolled HIV. These are all patients which you need to watch them very closely, because they're likely to progress to mild to moderate to severe disease, all right? So this one table will summarize everything what we're talking about. So if you see here, The patient can be from asymptomatic patient to the very critically ill patient. And I want you to focus on this proposed disease pathogenesis, right? So when the virus enter, then the viral replication is started. In the early mild disease, there's only the viral replication that I showed you in the earlier picture. And toward the moderate to severe disease is all because of inflammation. But when there's inflammation start, then that's the time patient can be a little bit more symptomatic, and after further progression, they become hypoxic and all the other further consequence and the sequelae of diseases because of the uncontrolled inflammation. So this is very important because now there is a trend that can we give a steroid and so help them early and prevent the further progression of disease. But what will happen is if we start the anti-inflammatory therapy way here in the mild disease, you might harm them because patients right now in a viral replication phase, and you might promote the viral replication. So it might be harmful. We'll see that down the road in other data. But if you put on any antiviral in the later phase, may not be helpful. And we do not have any good antiviral beside the remdesivir. And in the early disease, they may be helpful, but they are not known to prevent any progression of disease, and there is no mortality benefit. So still there is not any routine use of the remdesivir, and especially in a resource limited setting, I don't think there is anything beneficial role beside the decreasing the symptomatic period on a few days. Antibody therapy could be helpful in a high risk patient in an early phase. But as you see in this table, there is no role of any other medication like a hydroxychloroquine, azithromycin, ivermectin, or any convalescent plasma. They are out of the picture. Tried that a lot last year, but not anymore. In the severe disease, when there is a lot of inflammatory cascade going on, patient is really sick, beside the dexamethasone or any kind of steroid, tocilizumab has shown some beneficial role. Earlier, there was a conflicting result, but lately there's some papers which shows that patients who are severely ill, tocilizumab can be helpful. So this is pretty much the summary for the management of the COVID disease. So when you have the patient with the COVID disease, more than the COVID disease itself, it is important to manage the patient as a whole, other comorbidities and the complication from the treatment and complication from the this excessive inflammation. So as I mentioned to you, in the mild disease, pretty much more the replication of the virus and a lot of viral replication, no inflammation at all. So at this point, so what are we gonna do? I think these are the patients a lot of us see, right? And there's lots of panicky, and every patient who are positive, they think they're gonna die. So at this time, this is very important from the healthcare point of provider point of view, is to encourage them. It's okay. Many patients do just fine. They do not need any investigation. Do not waste their resources and hospital and the patient resources and doing a whole bunch of tests. As I mentioned earlier, every test should have a reason. If not gonna change your management, there's no need to do it. A lot of patients with the low-grade fever, myalgia, headache, and diarrhea, they do not need any specific investigation besides the diagnostic testing with the antigen testing or PCR. You educate them for the home isolation and monitoring to prevent the transmission to the other family member. You can follow them with the telemedicine. More important is, at this point, we might forget to take care of other diseases, such as hypertension, diabetes, heart failure, asthma, diabetes mellitus, right? So focus on, do they have any comorbidities, and focus on that. When you do not take care of other comorbidities, that might potentially kill them, not the COVID virus. And it is common that we are so much distracted because of this COVID diagnosis, and people are dying because of other disease, not particularly from the COVID. And in the mild disease and moderate disease, we will help them not doing a lot. Doing less will be more on this patient. But important things to remember is, then when do you feel alarmed? When to advise them, do not just stay at home. So we are in the extreme. Oh, I don't want to go to the hospital because I'm not going to get any care anyway, because there's no treatment for the COVID disease. I rather just stay at home, and being a doctor, as we don't have a bed, just stay at home and continue to do some home remedies. So the important things to know is, when do you call them? No, it is not safe for you to stay at home, come to hospital, right? So when do you get alarmed? So you send that patient home, and now when do you tell them do not stay at home? So if they start having this chest pain, altered mental status, means they is not in this phase of just the viral replication. Maybe the inflammatory cascade is more now, and this patient might need further evaluation in person, might need some diagnostic testing. So you have to advise the patient if they're complaining of I'm having more trouble breathing, I'm having chest pain, and if the family member reported they are altered, then definitely this patient need to be evaluated to make sure, is there other secondary process going on or not. When you see them, and if there is opportunity to get the pulse ox monitoring at home, and if their pulse ox is less than 94, 93, that means they are going toward the hypoxic phase and they need to be evaluated. You do again all the testing to rule out your differential diagnosis. If they're having fever, based on where you located, check for all the other possible reason of fever. It is not uncommon to miss the urinary tract infection and having a fever who had a COVID PCR positive. If we do not treat that, they can go to the urosepsis and can die. The people who are having a diabetes and a COVID positive, they can go to the diabetic ketoacidosis, and diabetic ketoacidosis can kill patient, but not necessarily the COVID. See how important it is? So those patients who have those symptoms, bring them to the hospital, do all the tests what you can do to rule out the other diagnosis and to make sure this patient is in a deteriorating phase. If there's alarming symptoms, you might need to admit in the hospital and monitor them in the hospital and provide a support. So now I'm going to check you with some clinical vignette, and if the time permits, I'll go all the way up to the ICU management, and let's see how much we can cover, right? This is a 47-year-old patient who has diabetes and hypertension. These are the risk factors for the poor outcome or severe disease. Having a cough, myalgia for 5 days, and on losartan and metformin, and not hypoxic, pulse is 94%. What are we going to do? He has a mild symptoms. He's not hypoxic, just only for 5 days. He might just do fine, right? So as there's not necessarily you need to do the CT and chest X-ray. I heard that there's a lot of practice going on to do the CT scan to identify the severity of disease. That is not correct. It doesn't help you. It doesn't tell you one way versus the other. Do not waste your resources. You can just tell them, go home, monitor your symptoms, take a good nutrition, do not just lay on the bed, continue to mobilize, take a precaution, and educate them when to come to hospital. Or if there is an option, you can do telemedicine follow-up. So we send home, and for the home isolation, you follow up in the telemedicine. Now you check the patient is having shortness of breath, chest pain, altered mental status. You advise the patient, come to the hospital. You check, blood pressure looks good. Heart rate looks a little bit on the higher side, 92%, almost there, going to be hypoxic pretty soon. Temperature is 102 degrees Fahrenheit, right? Check the blood test. There's a lymphopenia, a little bit elevated in creatinine. See, the most important thing here is the blood sugar is 250 on. And chest X-ray did mild opacity. So at this time, as I mentioned before, check for a typhoid if you have a suspicion. Check for the malaria, check for the urinary tract infection. Do all your due diligence to make sure what is the reason for the fever and all. So, there's no role of the empirical antibiotic, but you have a clinical suspicion that there could be other disease processes, and it's okay to start on empirical antibiotics, but try to de-escalate as early as possible. Continue supportive care. At this time, no role of steroid and remdesivir. So this patient, you admit in the hospital, you didn't give a steroid, you continue to monitor. Now in the third day, the oxygen saturation 87%. It's not your fault. It's not that you didn't start a steroid and that's why the patient got sick. This is the natural trajectory of the disease. On the third day, now you are seeing hypoxia, and a patient become febrile. Patient may say, doctor, I'm feeling better, but Now you know patient is hypoxemic. In the picture that I had shown you, patient started had a lot of inflammatory response already, and it might continue to progress further. So this is the time you start on dexamethasone. And a remdesivir, yes, you may start if you have it, but you have to make sure when not to use a remdesivir. If there is a elevated liver function, more than 10 times of upper limit of normal, if there is an acute kidney injury with the estimated GFR of less than 30, you should be avoiding that. And if it is a more than 10 days, as you know that there is not much of the viral replication, may not be helpful. So in the resource limit setting in the Kathmandu, if you cannot give a remdesivir, do not worry about it. The outcome will not change whether the patient got the remdesivir or not, all right? Focus on the comorbidity management. As I mentioned, this patient had a blood sugar of 250, and now you're giving dexamethasone, it will be out of control. You have to really care about how do you control the, your diabetes. Maybe the metformin is not the best choice at this time for you, and you may need to start on insulin. So it is reasonable if you can manage the blood sugar tightly, less than 150 milligram per deciliter in Kathmandu. In Nepal, I think it's going to be presented in the millimole. On your usual lab values, you know, try to control this tightly. Once you admit the patient, as you know, this patient already started having the coagulation cascade. It is very important the patient to be on a DVD prophylaxis. Let's talk briefly about the steroid. When the steroid is helpful, the big trial is a recovery trial. Recovery trial did show that dexamethasone 6 milligram for 10 days has been helpful. It prevents mortality. People taking the prednisone, dexamethasone, they were likely to survive. Those who didn't get it, likely to die. With this information, there's a lot of misuse of steroid, I would say. Is all can we give to everybody when they are PCR positive? Will that be helpful? Can we give for a month? Is more is better. So we will discuss further, okay? And if there's no dexamethasone, you still can give other kind of steroid like a prednisone, methylprednisone, or hydrocortisone. The bottom line is we are giving this dexamethasone or other steroid to calm down the inflammation, which is more than necessary to kill the virus, right? So in the recovery trial, this is the graph Kaplan-Meier curve I would like you to see. In the all the participation, the usual care means without the dexamethasone, with dexamethasone, there's a mortality benefit. The mortality benefit was there even more pronounced in the patient who are in a mechanical ventilation. And those who are hypoxic also, there is improved outcome with the decrease in mortality in a dexamethasone group. But look, this is the key. Those patients, among all those patients, when they check only those patients who had no hypoxia, those patients who were not on oxygen, but getting dexamethasone, they're likely to die more than those people who are not in dexamethasone. So that's why giving the dexamethasone to everybody is not good. If you give a dexamethasone in a mild to moderate disease or early disease, you might harm patient. Is it just because of the COVID, or is it because of the adverse effect? We do not know. The patient who are not hypoxic, if you give a steroid, the outcome will be not good. You might harm. Definitely no benefit, but you might harm. So be very careful. So why the steroid is not good all the time is steroid is, as you all know, it will be difficult to control the diabetes. If they are not diagnosed diabetes, undiagnosed, they will be diagnosed because they cause hyperglycemia out of control. More so, it will increase the risk of precipitating diabetic ketoacidosis. As you know, in Nepal and India, there's a lot of fungal infection, mucormycosis. The number one risk factor for the mucormycosis is diabetic ketoacidosis. All right. In Nepal, the TB, latent TB is not uncommon, as you all know. There's increased risk of reactivation. And in Nepal, the helminthic infection, strongyloides, is not uncommon. If you put on a high dose of steroid for a prolonged period of time, there can be the strongyloides hyperinfection, and that can be fatal, not the COVID. So keep in mind that steroid is not a benign drug. It is a double-edged sword. You have to use it very carefully. So now, this disease which was mild, you sent home, brought to the hospital. It was kind of the moderate disease, now progressing toward the severe disease. By the 5th day, there's no change in the X-ray. You are controlling the blood pressure very well. Patient oxygen is worsening and now in a venturi mass. It is not your fault. This is how the disease is gonna go. So tell the patient it's okay. This is what we expect. We'll continue to support with the dexamethasone, continue to manage other comorbidities. Now, by the day 10, the oxygen improvement is improving to 4 liters. So sometimes patient will be in the hospital for days and weeks. We have to have a patient being a provider. There's nothing to be panicked, and we have to hold the hands. ठिकै छ बामा यस्तै हो अब बिस्तारै ठिक हुन्छ लामो सास फेर्नुस् भगवानको नाम सम्झेर जप्नुस् भन्ने हो हैन it takes time, it takes a lot of time, sometimes weeks and weeks. So this patient got better by day 10, oxygen requirements is improving, so that this is time for you to remember in day 10 you have to stop steroid. Giving longer doesn't mean you're gonna help. All right. So by the day 10, by the day 15, you can discharge, patient got discharged home on 3 liters of oxygen if there's a feasibility that you can send home with home oxygen. All right. So this is the patient who came with the mild symptoms, who could have just done fine but didn't get better, went off to the severe stage and got better. Let's see the other patient, right? So this is a friend of the previous patient who was also a smoker and has a chronic bronchitis, has a more risk factor not to do well. Right, also got admitted because of a worsening dyspnea. On admission, had a chance to do the D-dimer, which is mildly elevated and not hypoxic. You admitted because you anticipated this patient not going to do well as well. On day 3rd, patient become hypoxic. We started a steroid. Day 7, oxygen requirement continued to get worse. By 10, oxygen did not get better, and venturi mass was not enough. Now you have to start on a high flow nasal cannula. You are in a good setup hospital where you had a high flow nasal cannula. So the patient condition is deteriorating. There's increase in a work of breathing, chest X-ray worsen. If you see the vitals, is more tachycardic, more tachypneic, saturation barely 90% and 90% high flow nasal cannula. You did a repeat the lab test, there is no leukocytosis, patient is not febrile, so less likely this is not any secondary infection, maybe just the progression of the disease. So when the patient in the hospital setting continue to have increased oxygen requirement, as you know, the complication we discussed earlier, there can be thromboembolic complication, right? They already have a microthrombi from the get-go. So could this patient have a pulmonary embolism? So you can check a D-dimer if you have an option, and if there's a really high increase from the admission, it was 2, now it is a 10, you suspect this patient might have pulmonary embolism or just the worsening of the parenchymal disease. If you have a luxury, or you can do it based on the renal function, you can do the CT angiogram. If not, you can just do the venous Doppler to rule out the DVT. If there is a DVT, you don't need to necessarily do the CT angiogram. You can just start an anticoagulation. If you do not have any resource, your patient is getting worse, there's increase in D-dimer, you can empirically start on a full anticoagulation. When you do that, you need to be very vigilant about the complication of the bleeding as well. And other thing is always pay attention, is there secondary infection? Is this a fungal pneumonia? Is this a secondary hospital-acquired pneumonia, right? In the prone position, there is no data, but it does help on oxygenation. If the patient can tolerate, if they are not in a distress and they can lay on their tummy, you can always encourage the prone position. Question is, can we give a tocilizumab, or what's the role of steroid? Over here in the United States, we do have easy access for the tocilizumab. At this point, we do start tocilizumab. But in the Nepal, if you do not have a tocilizumab, you are only with the steroid. Now the question is, should we increase the steroid? We do not know. We do not have a data. So not every patient, as I mentioned, not all patients who got the dexamethasone from get-go do better. And the same thing is not the 6 milligram per every patient. There are some few patients who might need a more than a 6 milligram, but how do you do that? Still, we do not have a lot of information. Some patient might need a more than 6 milligram of the dexamethasone. There's some trial going on. There was a trial in the Brazil. An ARDS patient, they give a 20 milligram of dexamethasone for 5 days and 10 milligram of dexamethasone for 5 days. So in some patient, if you have no other reason, but there is increased parenchymal disease, inflammatory markers, if you have a luxury to check, if you continue to go high, CRP more than 7.5, you have a more inflammatory disease in the CT scan. Now, that time, if you do not have a tocilizumab, you may give a higher dose of steroid. What's the higher dose? We do not know. There's an anecdotal experience on every center in the US. In my center, we give a dexamethasone of 20 milligrams. Is that a standard? No, we do not know, right? But the bottom line is just giving the higher doesn't mean better. As I showed you earlier, in the recovery trial, people who were in a mechanical ventilation, just a 6 milligram dexamethasone group had a better mortality. At this time, so that is by case basis. If you have enough information that you patient might need a more dexamethasone, you might give a dexamethasone higher, or if you need methylprednisolone. But one thing what we know is a higher dose of the steroid comes with a more complication. Definitely, if it is like a more than 250 milligram of methylprednisolone, they do poor. They have a more complication. So it is not uncommon when I come, talk with my colleague in Nepal. That's methylprednisolone 125 Q6 means you are giving a lot. If you give something, it may be just like a maximum of like the 20 milligram of dexamethasone is a methylprednisolone, maybe around like 100 milligram, but definitely not a high dose. Even if you have to give a steroid, make everyday assessment to bring to the lower dose and the shorter duration possible, because the fungal infection in Nepal and India, what I strongly believe, I think it is not because of the COVID, but I think it is because of the treatment. Most likely, we don't have much of the data, but if you have uncontrolled hyperglycemia with the excessive steroids, there is a definitely increased risk of fungal infection. So complication is, as I mentioned, there's a fungal infection. The mucormycosis, the #1 risk factor for the mucormycosis, uncontrolled diabetes with the DKA. I have seen at least about 2 cases in the United States with uncontrolled diabetic ketoacidosis, and they came very late stage. In Nepal, what I know is I think it's not so easy to get an ANMF in every lab setup, especially in outside the Kathmandu. But if you have a luxury, you can check the ANMF. The formula is sodium minus the sum of the chloride and the bicarbonate. If it's more than 16, you very likely have some gap acidosis there, even if the ABZ looks shows normal pH. Other thing you can guess is ketone in the urine or the blood. That means your patient very likely to have a diabetic ketoacidosis. If you do not treat the diabetic ketoacidosis, your patient gonna die. Not because of the COVID, it's because of the not noticing this patient in diabetic ketoacidosis. Diabetic ketoacidosis is a treatable disease. You don't need a lot of resource. You just need to notice and you need to treat it. So that's how it is so important when we managing this patient with the COVID. This patient may not die necessarily from the COVID, but will definitely die if we do not notice diabetic ketoacidosis. Even if he or she survive from the diabetic ketoacidosis, very likely can have mucormycosis, and which will be potentially lethal. Other hospital-acquired infection and delirium and GI bleed, there are other immediate complications from the steroid use. So let's see what happened to our case. In a day 15, this patient continued to improve to 60%. Blood sugar well controlled, and patient is febrile. Now you continue to watching the hemoglobin because the patient is in full anticoagulation. If the hemoglobin is more than 7, you don't need to transfuse, all right? If you transfuse the patient with a hemoglobin of 7 grams or lower, that's beneficial. But if you give blood transfusion more than 7, we know that that patient will have a poor outcome, irrespective of what disease. So we select be very careful about a blood product. Blood product comes with the cost all the time. So this patient was subsequently discharged home in 6 weeks. on a nasal cannula. This is a long duration, 6 weeks being in the hospital. The patient, the family, and the doctor all have to have a lot of patience. Yes, we'll continue to do better. It's gonna take time. It's just the time. Time is the treatment here, all right? And if the patient has a PE, most likely it's gonna be 3 months of anticoagulation. Now, with the interest of time, I'm just going to touch upon the severe disease. There is another patient which is also 65-year with a lot of comorbidity, if you see here. Diabetes, COPD, chronic kidney disease, current smoker. Came to the hospital with 3 days of worsening dyspnea. And then patient was having symptoms for 7 days of fatigue and fever. When patient came to the emergency room, the pulse ox was 82%, all right? And fever 103, patient is already distressed. You did all kind of the blood test and investigation, and the PCR was positive for SARS-CoV-2. So at this point, this is a COVID disease, but you're not sure is this patient having other disease process as well. So likely this patient not gonna do well because of so many comorbidities. We admit the patient in the intensive care unit. You have a consultant with you. Patient is now in 100% of oxygen with saturating only 89%. You started an empirical antibiotic for communicable pneumonia. You started an dexamethasone. You tried to put the patient in a awake prone position. You tolerated. Now you're in the ICU, so the targeted goal for your blood sugar control is from 140 to 180. Now, this is the patient you will have a real challenge with facing with a lot of complications. So in the second day, the patient is not doing so well, but the saturation maintained 90%. You did a chest X-ray. Chest X-ray, you see the air in the neck. That is a subcutaneous emphysema, and there's a pneumomediastinum. The sick people can have a pneumomediastinum and a pneumothorax, but there's nothing to do for that. Continue to watch. There's no intervention, but you be prepared that there's more complication is coming. All right. At this point, yes, if you have a tocilizumab, you may use it. In the third day, this patient didn't do well. Saturation continued to decrease, 82% on a high flow, 100%, and patient in respiratory distress, right? Breathing in 30 times a minute. So you have a round with your consultant, and patient got intubated. After intubation, this patient did well. Briefly, a patient even had a chest X-ray to confirm the ET2 placement confirmation. Within half an hour or so, the patient saturation started dropping, and patient blood pressure up to 60 and heart rate of 130. What happened? You see so this is a collapsed lung patient that a big pneumothorax. Patient is going to go to the tensor pneumothorax. So this patient need emergent chest tube placement. So you ask your senior or consultant, got the chest tube placement, got it stabilized a little bit. Now that you did a blood gas in an hour, PCO2 is 65 only. Patient is 100% FR2. This is not good. So we call it this PF ratio. Your arterial oxygen divided by the percentage of FR2. This is a 1, right? 65 divided 1 means this is a PF ratio of 65. Anybody who have a severe hypoxia in a patient where ARDS, what we know is a prone ventilation saves life and has an improved mortality. So if it is possible in your place, consider prone ventilation. If you have not done it, try to learn. People who are in ARDS and they are prone ventilation, it saves lives. But for that, you need to prepare with other logistic of central line, airline, and you might need to deeply sedate this patient. One thing I wanted to just let you focus here is now, depending on your training level in your expertise, what we know is the moment we put the patient on ventilator, there's a risk of the complication, and we might harm patient just putting on a ventilator if we do not provide the ventilation well. We call like a long protective ventilation. In the long protective ventilation, I want you to remember 2 things. The tidal volume, depending on the pressure control ventilation or volume control ventilation, tidal volume we wanted to deliver is 6 ml per kilo predicted by. That is called low tidal volume, and that is a long protective ventilation. And other thing is a pressure. the pressure, you can check the plateau pressure. For those who are not familiar with the vent, it will be difficult to check, but if you see in the pressure waveform in the top of the graph, that is the peak pressure. If the peak pressure is 30, your plateau pressure is always less than 30, so you don't need to worry about it. If you cannot measure the plateau pressure, that's fine. Just check the peak pressure. If the peak pressure is less than 30, you're good. Now, the ideal body weight calculation formula is here for male and female is different, is easily available everywhere. Other thing is you can also have a pocket card. What's the tidal volume for the male and female? In Nepal, most of us in a 5-foot range, right? In a male, anywhere from 5'3" to the, if you see on a 5'9", see the tidal volume, 6 ml per kilo, is never more than 450. Anybody in the ICU in Nepal, if the tidal volume is 450 in a male, that means you are giving a high tidal volume. You are not helping that patient. And the same thing in the female, right? If you see in anybody in the 5'3" to 5'9" range, the 5 feet and 9 inch female, 6 ml tidal volume is 400. Any woman in the ICU in Nepal getting a more than 400 of tidal volume, they are already in a more than 6 ml. Pay attention. This is very important. This is what we always say is do no harm, right? If you have any patient on a mechanical ventilator, if you remember these two things, you helping that patient a lot. So as I mentioned earlier, prone ventilation is considered in the refractory hypoxia. We call like a PF ratio of less than 150 with the FR to more than requiring more than FR to of 60 with appropriate trip. When you prone, at least if they're taller, we wanted to prone for at least for 16 hours. And when do we stop the prone ventilation, right? If the FR you can bring to less than 60, PF less than 10, and a PF ratio is more than 150, at that time you can consider stopping prone ventilation. The course can be even prolonged for this kind of patient. If they are getting better, you have to always think about to D-line the foreign bodies. It's like remember the central line, A line, the chest tube. Is it ready? You have to check every day when we can get these lines out. And other complication when they're in a ventilator, you have to deeply sedate and paralyze this patient, and you have to make sure are they getting any neurological complication. Always try to do the sedation vacation, and if there is not a good neurological exam, not moving the legs, they may not follow command, but if they are not moving the leg with painful stimuli, you might need to consider, could there be the stroke? So this patient had a stroke, MCA territory stroke, and then patient had a trach. But there is a scenario in the patient in the second week of the hospitalization in the ICU was apparently getting better. All of a sudden, patient get a fever of 104 degrees Fahrenheit. Patient become hypertensive. We did a chest X-ray, they even more further worsening of infection. This is not a COVID. This is hospital-acquired infection. You should start on a broad spectrum antibiotic. You are way out of the COVID viral replication. You did a blood culture, right? You see here in the blood culture, we are about a 5 minute more history. So blood culture came positive for 3 organisms. Guess what? Why? If you have a polymicrobial bacteremia, there is always a risk of gut translocation. This patient who is in the hospital with the steroid for more than a week now has a multiple bacterial growth in the blood. Very likely this is a gut translocation. This could be the case of the strongyloides hyperinfection. If you see the chest X-ray, chest will be a lot worse. And if you see the Stulova parasite, you might see sometimes you can get the strongyloides in the sputum as well. If there is a risk on any patient, you can treat empirically. I think treating the helminthic infection in a patient who need a longer steroid dose, it is fair to treat this patient with ivermectin. So if the patient reached to this point, very likely this patient with a refractory hypoxia and refractory shock, prognosis is very grim and likely to be lethal, and this patient didn't make it. So sorry, I went a little bit off and given time. Christy and Pooja, thank you.
sir, for this much needed insightful session. It has certainly broadened our horizon of knowledge on the crucial issue of COVID management. We have posted the link to the post-test evaluation form in the chat box. We would like all of you to fill the form before the webinar ends. We are entering into the Q&A session of our webinar. We will be taking questions and queries from our participants. May I request Dr. Ramit to answer our first question. It goes like this. What is the wait time to get vaccinated after COVID recovery and how it varies with different strains? What are the latest updates, if any?
अब कोभिड इन्फेक्सन भइसकेपछि चाहिँ के याद गर्नु पर्यो भन्दाखेरि the number of cases that have been seen right after an infection is pretty low. तपाईलाई यदि भर्खरै इन्फेक्सन भएको छ भने र तपाई रिकभर भइसक्नु भयो भने चाहिँ फेरि अहिले इन्फेक्सन भइहाल्ने चाहिँ चान्स एकदमै कम छ। त्यही भएर भ्याक्सिनलाई कुर्न चाहिँ मिल्छ हैन। सो द क्वेशन इज कहिले लाउन मिल्छ भन्दा पनि भ्याक्सिन छ कि छैन पहिला सुरु त्यो हो। र भ्याक्सिन छ भने तपाई भन्दा अरु कसैलाई बढी चाहिएको छ त भन्दै अरु कसैले पहिला पाएको राम्रो हो है। अलिकति जनरल रेकमेन्डेसन गाइडेन्स हेर्नु भयो भने चाहिँ रिकभरी भइसकेपछि 10 to 14 days after a positive test
sorry,
Amitji,
sir.
are you
You are mute.
you muted? Dr. Amit? Okay.
Sorry, okay. मैले unmute गरेको थिएँ तर पाएन। So मैले के भन्दै थिएँ भन्दाखेरि इन्फेक्सन भइसकेपछि भ्याक्सिन तपाईलाई अहिले चाहिएको भन्दा पनि अरु कसैलाई चाहिएको छ कि छैन भन्ने कुरा चाहिँ इम्पोर्टेन्ट हो। किनभने इन्फेक्सन भएर रिकभर भइसकेपछि फेरि अहिले तुरुन्तै इन्फेक्सन हुने चान्स चाहिँ एकदमै कम छ है। त्यही भएर एक त भ्याक्सिनको सप्लाई छ कि छैन र अब युएस को रेकमेन्डेसनहरु भयो भने चाहिँ सीडीसी ले के भनेको छ भन्दाखेरि यु क्यान गेट द भ्याक्सिन आफ्टर यु रिकभर फ्रम द इनिशियल इन्फेक्सन। So about 10 to 14 days after a positive test अथवा onset of symptoms, you can get the vaccine. तर नेपालको कन्टेक्स्टमा भन्दाखेरि in the next 3 months, very less likely to get another infection. जो मान्छे इन्फेक्सन लागेर रिकभर भइसकेको छ उसलाई फेरि अर्को इन्फेक्सन हुने चान्स कम भएको हुँदाखेरि चाहिँ अलिकति कुर्दाखेरि पनि फरक चाहिँ पर्दैन। सो एउटा प्र्याक्टिकल अप्रोच लिने हो भने चाहिँ त्यो रेकमेन्डेसन फलो गर्नु पर्यो। र नयाँ स्ट्रेनहरुको कुरा गर्दाखेरि चाहिँ we don't know the true numbers about vaccine efficacy. So we will only have more data available next year. So अहिलेलाई भ्याक्सिन रेकमेन्डेसन जुन अवेलेबल छ त्यो लिने र अब नयाँ स्ट्रेनलाई काम गर्छ कि गर्दैन भनेर त्यो there are no guarantees and we don't have the information.
Thank you, sir. I'd like to direct this next question to Dr. Raju. There is a trend of prescribing ivermectin and doxycycline in COVID as prophylaxis. Does it have any importance?
It's a good question. I was anticipating this question. Ani सीधा क्वेशन चाहिँ छैन। मैले भने नि कोभिड को पेशेन्ट को ट्रिट गर्दाखेरि चाहिँ if you have no other indication for doxycycline use, it's not help. And now it is about like 18 months that we've been treating COVID patient. There's no help, no helpful from any kind of antibiotics. If you have a suspicion for other bacterial infection that you have to use, it is okay to use empirically. But the moment you find there's no such infection, you have to stop it. Doxycycline or any kind of antibiotic usually drug resistance bug. त्यसको लागि चाहिँ प्रब्लम हुन्छ त्यही भएर डक्सिसाइक्लिन कुनै पनि युज छैन and which is not maybe not now it is well known there is no role of any antibiotics. Ivermectin is the same. Initially there was like some paper that could be beneficial. There is no any roles of ivermectin as well. I'm a Dr. Ramit, infectious disease expert. I'll get opinion from Dr. Ramit as well. In our institution, at least in America, we do not do at all. Dr. Ramit?
We don't use doxycycline.
Of a practical, pragmatic point of view, Nepal our helminthic infection is so common, right? And you be putting the patient on long-term steroid and you wanted to treat, I think you are not wrong. But not to use ivermectin from a get-go. This patient has a COVID. Now I want to give ivermectin to prevent. That is wrong. So what I can tell you is using the ivermectin and a doxycycline, we definitely know there's no beneficial role. You might harm, but you cannot justify yourself that you are doing it right. You might harm. So I will suggest not to use that. Thank you.
Thank you so much, Dr. Razu. Now, I would like to direct another question to Dr. Ramit. Is mRNA vaccine safe for non-immunocompromised individual? I repeat, is mRNA vaccine safe for immunocompromised individual?
So मैले अघि भने जस्तै जुन immunocompromised पेशेन्टहरुमा चाहिँ सेफ्टीको चाहिँ डेटा अवेलेबल चाहिँ छैन तर there is no reason to say that it is not safe. Right? The main question in this population is about efficacy. So vaccine कति effective छ immunocompromised पेशेन्टहरुमा त्यो चाहिँ हामीलाई थाहा छैन तर safety को चाहिँ there is no concerns. है अहिलेसम्मको हामीलाई थाहा भए अनुसार चाहिँ
म त्यसमा एउटा point थपौं
हजुर
अनि अब immunocompromised पेशेन्टलाई सेफ्टी र एफिकेसी छ लिने कि नलिने भन्दा चाहिँ मेरो पेशेन्टहरु मेरो धेरै अनि लङ क्यान्सरको ट्रिटमेन्ट भइरहेको पेशेन्टहरु म पल्मोनरी क्रिटिकल भएको भएर त्यस्तो पेशेन्टहरु आउँदा म के भन्छु भने you will likely to do very poorly if you get a COVID. Only way we can minimize that with the vaccination. एउटा कुरो के थाहा छ भने कोभिड त्यस्तो मान्छेलाई भयो भने चाहिँ he will not make it. He will die. He likely to die. That's the patient. So you do everything to minimize even a 1% chance of benefit. You have to use that. So for that token, I would suggest to take the vaccine for all the immunocompromised without any doubt.
Thank you, sir. I'd like to direct this question to Dr. Raju again. So our question is, there are various other steroids like hydrocortisone, methylprednisolone. What are the advantages of dexamethasone over these varieties of corticosteroid, and can these be used in children and elderly as well?
अब dexamethasone चाहिँ किन भनेदेखि चाहिँ रिकभरी ट्रायल चाहिँ dexamethasone गरेको भएर सबैले dexamethasone भन्ने हो but pathophysiological perspective मा हेर्दाखेरि चाहिँ it is all because of the inflammatory cascade. We wanted to calm down the inflammatory response. त्यही भएको भएर चाहिँ equivalent dose of the other steroid you can also use. त्यही भएर मैले राख्दाखेरि चाहिँ prednisone equivalent dose is about 40 and तपाईले equivalent dose of the methylprednisolone and hydrocortisone सबै नै कुनै जुन अवेलेबल छ त्यही चाहिँ युज गर्न सकिन्छ. त्यही भएर पहिला त हामी अमेरिकामा चाहिँ very commonly we use methylprednisolone before the recovery trial. But after the recovery trial, if you have a dexamethasone, you can use it irrespective of the age group. And if you do not have a dexamethasone, you can use the equivalent dose of the dexamethasone, other formulation, prednisolone, hydrocortisone. Thank you,
Thank you so much, sir. Now, I would like to direct the next question to Dr. Ramit. we have been seeing a lot of people vaccinated first dose with Covishield and second dose with Vericel, and even some vaccinated completely with both types. Is this efficacious? Can you comment on this?
हजुर यो पनि अब एकदम कमन सिचुएसन नेपालको कन्टेक्स्टमा हगि अब भ्याक्सिनेसनको यो क्वेसनहरु अराइज हुँदाखेरि चाहिँ हामीले अगेन प्रिन्सिपल्स अफ भ्याक्सिन के हो त भनेर सोच्नु पर्यो हैन भ्याक्सिनले त इम्युन सिस्टमलाई एउटा ट्रिगर मात्र गर्ने हो र यो कहिले दिने भन्ने एउटा जनरल गाइडेन्स चाहिँ यो ट्रायल्सको बेसिसमा हो है सो अब जस्तै हामीले इयरली फ्लू शटहरु लिँदाखेरि अब कुन चाहिँ ब्रान्डको लियौं के हो भन्ने त्यस्तो हामीले नोटिस गर्दैनौं किन भन्दाखेरि इन जनरल एउटा बडीलाई ट्रिगर गर्ने इम्युन सिस्टमलाई ट्रिगर गर्ने हो त्यही भएर हामीले कोभिशिल्ड लियौं अथवा भेरोसेल लियौं भन्ने हामीलाई फरक चाहिँ पर्दैन किन बडीले रेकग्नाइज गर्छ र रिएक्ट गर्छ अनि इम्युन सिस्टम जब ट्रु एक्सपोजर हुन्छ तब बडीले सिभिरिटी अफ द इन्फेक्सन अथवा एसिम्प्टोमेटिक होस् भन्ने त्यो पर्पज हो त्यही भएर एक चाहिँ एउटा मात्र डोज पाए म के गरौँ भन्नेहरु चाहिँ केही नहुनु भन्दा त एउटा डोज पनि बेटर हो भन्ने कुरा त्यो पर्सपेक्टिभ हुनु पर्यो मान्छेमा हैन र एउटा डोज पाए अब अर्को कम्पनीको पाउँदाखेरि के नराम्रो हुन्छ त भन्ने हैन यो भ्याक्सिनहरुको सबैको गोल एउटै हो हैन त्यही भएर यति ड्युरेसनमा मेरो मिस भयो अब 4 हप्तामा पाउनु पर्ने 3 हप्तामा पाउँदा के हुन्छ त भनेर सोच्छन् मान्छेले केही फरक पर्दैन त्यो स्टडीमा चाहिँ उनीहरुको जनरल रेकमेन्डेसन म्यानुफ्याक्चररको 4 to 12 वीक्स हुन्छ तर अब 14 हप्तामा पाउँदा पनि बडी विल स्टिल रिएक्ट अब स्टडी ट्रायल गरेर यदि एफिकेसीको कुरा गर्यो भने इट माइट बी डिफरेंट बट फर एन इन्डिभिजुअल हैन इन आइडियल सर्कमस्टेन्सेस यस यु वान्टेड 2 doses in certain duration. But in practical situation, if it's not possible, you take what you get. हैन भनेपछि जुन अवेलेबल छ त्यो लिने जुन अहिले नेपालको सिचुएसनमा प्र्याक्टिकल अप्रोच चाहिँ बेटर भयो युएस को सिचुएसनमा चाहिँ अब यदि जन्सन एन्ड जन्सन जस्तो सिंगल डोज भ्याक्सिन अवेलेबल छ भने फर्स्ट डोज फाइजर लिएर सेकेन्ड डोज जन्सन एन्ड जन्सन लिन पनि मिल्यो हैन there's no published data on the exact efficacy, but my suggestion is that you take a practical approach and you get whatever is available.
Thank you, sir. I'd like to direct this next question to Dr. Raju. Isn't it better for any positive case to get a CT considering X-rays to be obsolete? And does CT severity score correlate with clinical severity?
Thank you, Drishti. मैले अघिको सुरुमा प्रेजेन्टेसनमा भने थिएँ कुनै पनि in the throughout the medical career we have to use the tools to guide what we're gonna do. Even in my ICU, if the test is not gonna change what I'm going today, I do not do it. All right. So question is, COVID PCR positive patient like CT scan गर्नु मा चाहिँ के फाइदा होला अथवा के कसरी गर्छ होला भन्दाखेरि चाहिँ यदि mild disease छ भन्दै चाहिँ as we know 80% or more people just do fine irrespective of what you're going to show in the picture, right? So if you're not going to change it, if they're not having any alarming symptoms of hypoxia, chest pain, shortness of breath, or you wanted to rule out other differential, there's no need. And there's no validated CT scoring severity so far. I think there is a local practice that a certain kind of a CT scan tells you that this is a severity. And I have read many CT scan that was sent from Nepal. ये मेरो CT scan यस्तो भएको थियो एकचोटी यसको severity हेर्दिनु भनेर भन्छ ल ठिकै छ अब के पनि छैन के गर्नु पर्दैन किनभने त्यो CT ले चाहिँ दुईटा कुरा एउटा यसले चाहिँ बिरामीको भोलि के हुन्छ भनेर पनि भन्दैन अनि त्यो सिटी स्क्यानले के गर्ने पनि भन्ने हुँदैन के भएको र मैले के भन्छु भने त्यो चाहिँ धेरै युजफुल नहोला किनभने इट डजन्ट गाइड यु अनि हामी यहाँ धेरै रिसोर्स हुँदाखेरि पनि कुनै नराम्रो सिटी स्क्यान देखेको पेशेन्टहरू मेरो धेरै घर गइसक्नु भएको छ अनि अहिले 3 महिना 4 महिनामा मैले फलोअप गर्दाखेरि पनि सिटी स्क्यान लुक्स स्टिल ब्याड radiological picture will not tell you how the patient clinical picture going to be right त्यही भएर युजफुल हुँदैन अर्को chest x-ray I think is not absolute we do not use it that much but is easily available everywhere the patient who are hypoxic patient who are having a chest pain maybe that is the easiest and earliest thing you can do it but if you suspect this patient might have a pulmonary embolism, maybe CT scan will be helpful. Otherwise, do not need CT scan just to stratify the severity. To give you my example, any patient who come to the hospital, मेरो हस्पिटलमा भर्ना भएको बिरामी चाहिँ वार्डमा हुँदाखेरि they will just get a chest x-ray अनि for the worsening of disease भएर चाहिँ ICU मा आउनुभयो अनि हाई फ्लोमा 80% 90% भयो भने म CT scan गर्दिन किनभने the risk of transporting that patient to the CT scan is way higher. अनि मैले गर्ने ट्रिटमेन्ट चाहिँ केही पनि छैन तर मेरो आफ्नै कारणमा म यदि त्यस्तो अनस्टेबल पेशेन्ट छ भने I rather treat them empirically with anticoagulation or ultrasound गर्छु तर CT scan गर्दिन त्यही भएर स्टेबल पेशेन्ट भएको माइल्ड डिजिज को पेशेन्टलाई CT scan को केही पनि युजफुल छैन Thank you.
Thanks so much, Dr. Razu. Now, I would like to direct another question to Dr. Ramid. What is the efficacy of any of the present vaccine against newer strains? Is it even of any use against newer ones?
Thank you. अब मैले अघि भने जस्तै there's studies that are going on. भर्खरै पब्लिश भएको चाहिँ Modernaको भ्याक्सिनको चाहिँ they modified their vaccine to use a spike protein that is specific to the newer strain. And they saw better results as far as protection against the particular strain. Overall efficacy भन्दाखेरि चाहिँ जुन नयाँ स्ट्रेनहरू छन् त्यसको स्पाइक प्रोटिन चाहिँ सिमिलर नै छ त्यही भएर efficacy is not significantly lower. But in the future, there are plans to make specific vaccines directed towards specific strains. But there is no large-scale trials and data that is already available. Thank you.
Thank you, sir. I'd like to direct this next question to Dr. Raju again. Do we have to taper the dose of dexamethasone after using it for 10 days, like by substituting with other steroids with low doses?
Usually 7 to 10 days of steroid, you can stop. So a lot of patients with the 10 days. Theoretically, कुनै पनि steroid भएपछि taper गर्ने भनेर सबै medical schoolमा पढ्यो नि त हैन तर अहिले छ अब during the COVID time, a lot of patients they stop the steroid in 10 days. तर अहिले मैले भने जस्तै steroid चाहिँ continue taper continue longer duration use गर्ने कि नगर्ने भने चाहिँ it's very case by case. Most of the patient they do just fine. But if you have a clinical suspicion that a patient causing CT scan of a chest X-ray looking diffuse parenchymal involvement, oxygen requirement is still quite a bit. And if the inflammatory marker check luxuries are still quite a bit, you can think of considering to taper down over week or 2 weeks further down. Dora, 10 दिन हुँदाखेरि चाहिँ पेशेन्टको oxygen very minimal, clinically almost back to the baseline छ भने चाहिँ त्यस्तो पेशेन्टहरुलाई चाहिँ I usually do not prolong. But some of my patients I had to put them back and forth. के हुन्छ भने when the patient in a hospital like 4 weeks and 5 weeks, you can taper down the steroid within 10 to 12 days, and the moment you stop the steroid, and their oxygen requirement can get worse. Their inflammatory marker can go up. Their CT scan shows it is more of the organized pneumonia like a pattern. There is fibrosis looking patterns. What that means is there is a lot of inflammation is still ongoing. This patient or saying dexamethasone dose is small maybe prednisone dose 3-4 हप्तामा पनि taper गर्नुपर्छ. So there's some paper now. There's some paper that a particular group of patients who have a interstitial lung looking like a picture, organizing pneumonia, tapering over the weeks, they are beneficial. But that should not be taken in account that all patients lamo didama thik huncha भन्ने चाहिँ हैन. त्यही भएर चाहिँ most of the patient को मा चाहिँ 10 days is enough. If you have any other clinical suspicion, in those kind of patients, you can taper and try to taper the earlier. And depending on the clinical response, few patients might need a prolonged taper as well.
Thank you so much, sir. Now, I would like to direct another question to Dr. Ramit. What % of population need to be vaccinated for a country to achieve herd immunity? Also, is it possible for a place, for instance, Kathmandu, to undergo herd immunity if a high % of population get infected?
Thank you, Pooja. You'd say alikati tricky question pani ho, kinabhane again we don't have a crystal ball. We don't know if herd immunity is possible at a certain level. That a US government could say target say at least 70% of the population vaccinate गर्ने हो. But we'll still see. मेरो personal opinion मा चाहिँ काठमाडौँ जस्तो ठाउँमा जहाँ चाहिँ vaccination छैन तर natural infection नै यति चाँडो spread गरिसक्यो र अब neighboring country जुन Indian strain आएर जुन हाम्रो early second peak ले affect गर्यो, it's already in a downward trend, which is good news, हैन? So herd immunity भनेको अलिकति hopeful त हो तर in reality nature has its own course, हैन? So Italy अरु कुनै देश जाने चाहिँ एकदमै peak नराम्रोसँग भयो र healthcare system crash भयो. जता पनि एउटा peak हुन्छ र trough हुन्छ र यो seasonal variation हुन्छ कि हुँदैन, यो नयाँ strainले कतिको affect गर्छ, यो difficult to predict. So I don't have a clear answer, but hopefully we will start to see downward trend of the cases.
Thank you, sir. Another question that I'd like to direct to Dr. Raju is, tell us something about post-COVID syndrome or long COVID.
Long COVID. So right now, I have quite a few patients. They are coming to see me after 1 year. Most of the patients, they do fine. Mild to moderate disease within a month or 2 months, they are back to their baseline. But those who require ICU hospital stay, or they were in a lot of oxygen demand and they are in their lot of parenchymal involvement, their recovery can be longer and depending on the other complication what they had. The radiological improvement in their pictures, sometimes it might take up to 3 to 6 months just for the improvement, not for the complete resolution. And few of my patients, they are almost close to 9 to 12 months and they still can have some changes in their lungs. So it's a kid they case COVID might cause a long-term chronic lung disease. Post-COVID lung fibrosis lungs related. Or oxygen requirement, it can be prolonged for weeks to months. And after that, if even the patient not having any hypoxia, they can have a post-infectious bronchial hyperreactivity. They can behave like an asthma patient. I know. Just the patient who has bronchodilator with the inhaled corticosteroid can be helpful. That can be lingering symptoms. other lingering long COVID symptoms and brain fogginess. Ani mero ta ani yo forgetful hune, I'm not not back to my baseline, my cognitive function. If you can ask them to unmute their microphone. Thank you. So, अर्को चाहिँ के हुन्छ भने lot of symptoms, common symptoms of fatigue, poor energy, and brain fogginess. अनि यो टाउको झुम्म भइराख्ने अनि मेरो अनि सम्झिने शक्ति चाहिँ back to normal नहुने चाहिँ सबै post COVID lingering हुनुहुन्छ. Few patients can also have a myocarditis, and it can take time. Other commonly noticed symptoms, complication is a new pulmonary embolism, right? At this time, we are treating pulmonary at least for 3 months of anticoagulant. It's still a provoked, but we're not quite sure. So you have to do the due diligence to check everything at the 3 months, whether you might need to prolong anticoagulation or not. So there's like a multi-system involvement in the post-COVID, and it's all from the neuropsychiatry to the dreaded complication is a pulmonary fibrosis. I think that's what the biggest thing we worry about.
Thank you so much,
Thank you,
sir.
Pooja.
I request everyone present here to mute their mic, and if they have any queries, please drop that in the chat section. Our speakers will address them. I would like to direct another question to Dr. Ramit. If there is more than 2 months of gap between first and second dose of varicella vaccine, self-vaccine will be repeated, or we can take second dose varicella beyond 21 to 28 days. What would be the extreme cut of gaps between two doses of varicella vaccine?
यो चाहिँ मैले अघि भने जस्तै there is no set recommendation, हैन? In my opinion, if it's been more than 3 months, then probably you should repeat the series, okay? But based on preliminary studies, the vaccine, the immunity developed from vaccines has been shown to be present even beyond 6 months. But in general, again, depends on the vaccine availability. But if you have waited more than 3 months, then probably you should complete the entire series again.
Thank you, sir. Another question I'd like to direct it to Dr. Raju. And the question is if tocilizumab increases the risk of mucormycosis.
Maybe. So एउटा के हो tocilizumab जति बेला सुरुमा लास्ट इयरमा हामीले युज गर्यौं पहिला, अनि tocilizumab को एउटा रिस्क चाहिँ के हो भने हस्पिटल इन्फेक्सन र अदर इन्फेक्सन को चान्सेस चाहिँ बढ्ने भएको भएर चाहिँ अनि त्यसको युज एकदम घट्यो फेरि. त्यही भएको भएर it might increase the risk of fungal infection, and it might also increase the risk of reactivation of TB and other hospital-acquired infection ko pani risk huncha. There are tocilizumab, I think you have to take with a grain of salt. Dr. Ramit, what's your take on the tocilizumab and fungal infection?
Again, hamroma चाहिँ because of cost issues, we have restricted tocilizumab. There is, in my opinion, a very short window of opportunity for use of tocilizumab. Even one dose costs about more than $4,000 in the US context. So I'm not against the use, but unfortunately, I feel like the benefit versus cost is kind of difficult to justify if we start using it in everybody who is hypoxic.
And this much, and we also have very limited use. And one dose, what I personally believe is one dose of tocilizumab not gonna save life. I think there's many other things to save life in the context of Nepal, where there is other risk of the other infection that you cannot monitor so closely, you have to be really careful about using the tocilizumab and high dose of steroid. In the developed country, we know we spend a lot of money and a lot of resources. So, but is it just the tocilizumab or high dose of steroid saving life? I do not think so. I think the back to the basics medicine in the bedside saves life, not 1 or 2 dose of remdesivir or tocilizumab. Steroid 6 milligram, absolutely. But other things is just maybe.
If I can just add my thoughts on management. यो पेन्डेमिकले millions इन्फेक्सन गराएको छ र एट दि एन्ड अफ द डे एउटा इन्डिभिजुअलको इनहेरेन्ट रिस्क हुन्छ जुन चाहिँ कसैले पनि प्रेडिक्ट गर्न सक्दैन एउटा 40 years old मेल किन भेन्टिलेसनमा छ र मरिरहेछ र एउटा 90 years old female किन एसिम्टोमेटिक इन्फेक्सनले बसिरहेछ भनेर कसैले पनि प्रेडिक्ट गर्न सक्दैन र यसको एउटा नेचुरल कोर्स हुन्छ अनफर्चुनेटली देयर इज भेरी लिटल एनी मेडिकेसन क्यान चेन्ज द्याट कोर्स भन्ने चाहिँ सबैले याद गर्नु पर्यो.
Totally agree.
Thank you, our speakers, for addressing and clarifying the queries of our audience. With this, we have come to the end of our Q&A session. We are extremely overwhelmed by the number of questions that we got in through the chat box, and we will have to apologize for not being able to address all of them because of the time constraint. Moving on with the event, we are pleased to inform you that we have with us Professor Dr. Sabina Bhattarai, President, Society of Dermatology, Venerology, and Leprology, Executive Director of Lavana Skin and Hair Clinic, Executive Member of Paila Foundation, and former Vice Principal and Head of Department of Dermatology, Kathmandu Medical College and Teaching Hospital. With more than 60 publications in international and national journals, she has been a presenter in many national and international conferences. Dear attendees, it is my absolute honor to request Professor Dr. Sabina Bhattarai to give vote of thanks for today's webinar.
Thank you so much, Drishti and Pooja and the entire Nepal Youth Movement Nepal. It's been a great honor to be associated through Paila Foundation in this webinar. And I would like to personally thank Dr. Vikas for inviting me to say the vote of thanks. And thank you so much, Dr. Rami Thapa and Dr. Raju Century. I think I know Raju Century from the PKHS days. So it's been an absolute honor to listen to you, though it's a common interest to all of us, but it was a great, wonderful learning experience. I actually sat through the whole thing, and it's like I've been enriched and enlightened by so many different educative things that you've told us. And the question and answer session was also very interactive. So it was, I think, a great learning experience from the Nepal side, hearing from physicians, great physicians, treating physicians like you from the other part of the world. So I think these type of platforms would definitely help people, help us and young people, because this is a movement which has been carried out by the young youths. I think most people have been involved in so many different social activities. And just to talk about what we at AK Paila is also doing, because this is, since we are also one of the supporting group of this webinar. So we're just a group of young volunteers who give some time out from our practice. And at present, for the COVID-19 crisis, we've been collecting funds from different beneficiaries, different friends and relatives, and different songs
Drishti and Pooja. Yeah.
I think ma'am lost her connection. Hello.
We'll wait for her to get back, but in the meantime, we also want to express our gratitude towards Nepal Youth Movement on your great medical team, medical branch, group of energetic young medical professionals. And we wish you good luck in all your ventures. And I hope things will get better in Nepal. तर धेरै खुसी लाग्यो सबैजनासँग इन्टरेक्ट गर्न र hopefully we can do this again.
And same token from me, मैले पहिलेदेखि भनिरहेको I'm so proud of you guys, Youth Movement, and thank you for choosing us and be a part of this presentation. अनि धेरै क्वेसनहरु आइरहेको थियो and my apology we couldn't cover that. अनि नेपालमा तपाईहरु जस्तो रिसोर्स लिमिटेड विभिन्न ठाउँमा बसेर अहिले यो केयर गरिरहनु भएको छ, that compromising your life, you don't have a good enough PPE, you do not have a good enough support, and you still need to worry about the family member come and beat you so badly. So नेपालमा बसेर सबै सेवा गरिरहनु भएकोलाई एकदमै धेरै धेरै धन्यवाद. Any question, anything concerning for everyday care or anything, please reach out to us. Pooja, Srishti, and Sriyanta. Kasako question, sir, if there's anything they need, they can reach out to me. Right? And our organization, America Nepal Medical Foundation, we've been pretty active, and you should have our contact, and please reach out to us if there's anything we can help you and manage any patient anytime. Thank you. Thank you, team.
Thank you, sir. Since Sabrina ma'am is back with us again, I'd request her to continue.
About to finish up my speech because it's getting late out here in Nepal, I think. So that's what we've been doing through Paila Foundation is we're distributing medicines to different people in so we're distributing basic essential medical supplies to patients who are homebound in very rural parts of Nepal. And we're also getting help to make isolation kits. And then these are all sent to people who are very poor and people who are in parts of Nepal. So the various local governments at the local level are helping us taking the medicine and giving it in each and every home. So besides that, we're also conducting a helpline. Phone numbers are distributed because our team consists of doctors of almost all fraternity. So that is also helpful for patients who can reach out to us in times of pandemic, in times of lockdown, because we have given a designated numbers and designated time frame where they can bring us up, and we will be very happy to solve any problems. So now that I've listened to all the presentations, I think if I get a call from the patient suffering from COVID or needs any advice on vaccination, I think I'll be able to, after the webinar, be able to solve some of their questions as well. So thank you so much. Thank you for enlightening us, and thank you for being with us. And it's been a really, I think we've had more than 500 participants in this webinar. So it's quite a huge number at this wee hours of the night. And so a very good day to Dr. Raju and Dr. Ramit. And thank you so much.
Thank you for the token of thanks.
Thank you, Sabina Didi. It's good to see you after many years.
I know, but you're just the same.
Thank you so much, Sabina. Sorry. Thank you so much, Dr. Sabina ma'am, for your insightful words. And we highly appreciate your works, and we wish good luck for the journey ahead. We are grateful for your support in our endeavors. I request our attendee to mute their mic, and if they have any queries, you can contact our speakers. Now, moving on with today's event, I would like to thank our speakers for an enlightening presentation on COVID-19 management and vaccination. Your experiences, your depth of understanding, and your ability to present the subject in such an interesting way produced one of the most beneficial webinars for all the attendees. We are grateful for the time and effort you took to share your knowledge, thoughts, and experiences with all of us. So as a gesture of appreciation, we would like to present our speakers, Dr. Raju and Dr. Ramit, virtual token of love as a special vote of thanks on behalf of NYM Nepal and everyone here for making this event a great success. May I please request Dr. Ramit and Dr. Raju to accept the virtual token of love with our sincere thanks. And we express our gratitude to Mr. Rohit Dahal for designing the wonderful creation.
Thank you, Pooja, and the entire team. We highly appreciate this token of love. And it's virtual, but it feels as good as real.
Indeed, it is. It looks real, and thank you, Pooja and Drishti and all the team. And I'm glad to get this honor.
Thank you, sir. To get updates on our future programs and initiatives, you can follow us on our Facebook and Instagram handles, the links to which have been posted in the chat box below. I'd like to take this platform to inform you all that National Youth Movement Nepal, in association with Rio Club of Kathmandu Empire and Nepal Red Cross Society, has been carrying out mobile blood donation campaign to meet the increased demand of blood in a time of crisis amidst lockdown when blood donation programs have been absolutely halted. With the completion of Phase 1 and Phase 2 inside Kathmandu Valley, NYM plans to expand the campaign to outside the valley in near future. Initiated with the motto, donate blood at your doorstep, it allows you to donate blood in your nearest feasible location. To know more about the campaign and contribute to it, you can visit the link posted in the chat box below.
With this, we have come towards the end of today's webinar. We would like to apologize for this disturbance. Speaker, Dr. Raju and Dr. Ramit, our program coordinators, Dr. Shayanta Kesi, Dr. Samana Rial, and the entire NYM Health Committee who have worked day and night for putting together this insightful event. Lastly, we would like to thank all our participants for joining in, for being such good listener, as well as actively participating in the discussion. Your cooperation is what made this event worthwhile. Thank you, everyone. Good night. Stay safe.
Thank you, everyone. Goodbye and good night.
Thank you, team. Good night.
Thank you, sir.
Good night. Good night, everyone. Good